Welcome to Talking PAH, a live webcast series. Today, discussing advanced clinical cases in reverse remodeling therapy, a new era in PAH. My name is Marc Imbert, and I'm delighted to be joined today by Dr. Aaron Waxman, Director of the Pulmonary Vascular Disease Program, Executive Director, Center for Pulmonary Heart Disease at Brigham and Women's Hospital Heart and Vascular Center, Harvard Medical School in Boston, Massachusetts. I am a professor of medicine at Université Paris-Saclay in the south of Paris, where I run the French Pulmonary Hypertension Referral Center. The learning objectives today are that upon completion of this activity, the participants should be better able to implement strategic measures to improve identification of clinical symptoms for prompt assessment and diagnosis of pulmonary arterial hypertension. Diagnose and refer patients with PAH to tertiary expert centers in accordance with guideline recommendations and with vigilance for comorbidities that may contribute to symptom burden. Evaluate the clinical trial data, safety, and efficacy of emerging therapeutics for the management of PAH, and formulate treatment plans for various points in the PAH disease stages based on individual patient factors. Let's start with the pathogenesis of PAH. We all know that pulmonary arterial hypertension has a complex pathophysiology. And there is a series of events from the initial steps where there is endothelial cell dysfunction and certainly some kind of vasoconstriction to more advanced disease. And with the progression of the disease, you have accumulation of cells in the pulmonary artery wall, characterized by medial hypertrophy, local release of cytokines and mitogens, and inflammatory cell recruitment. Remodeling will advance more and more, and there will be marked medial hyperplasia, extracellular matrix remodeling, metabolic shift, and phenotypic switching. So there is a stepwise progression, and in that progression, the immune system is important, but the pulmonary vascular remodeling is key. It will lead to increased pulmonary artery pressure, increased pulmonary vascular resistance, and at the level of the pulmonary circulation, endothelial cell dysfunction, smooth muscle cell hyperplasia are truly important. This will influence the right side of the heart with initially right heart hypertrophy and then dilation, pericardial effusion, and fibrosis of the myocardium. Myocardial ischemia may occur during the progression of the disease. There are different predisposing factors and modifiers which will trigger or influence the natural history of the pathophysiology of PAH. What is truly important is to know the definition of pulmonary hypertension. And I will start with the first poll question at this stage. Which of the following is not part of the diagnostic definition of precapillary pulmonary hypertension as measured during right heart catheterization? So which is not part? Negative question. A mean PAP above 20 millimeter of mercury. B, a pulmonary artery wedge pressure of 15 millimeter of mercury or less. C, right atrial pressure above 10 millimeter of mercury. D, pulmonary vascular resistance above 2 Wood units.
Mark, while we're waiting for the polling to come in, I was wondering if you could explain how the hemodynamic definition of pulmonary hypertension has changed, especially with the new guidelines, and briefly what data actually drove those changes.
Yeah, thank you, Aaron. It's a very important point. Traditionally, there were some definitions which were based on expert opinion and expert group decision in the 1970s and 1990s. These definitions were more expert-based. Then recently we performed a series of systematic analysis and meta-analysis, which allowed us to define properly what is a true normal value, what is a standard deviation, and what is the upper limit of normal. So thank you very much for this question. Most of you consider that what is not part of the diagnostic definition is indeed a right atrial pressure above 10 millimeter of mercury. Indeed, in the definition of PAH, we have not consider right atrial pressure, which is more a marker of severity, hemodynamic severity of the disease. So let me develop a little bit on that. So the hemodynamic characteristics of pulmonary hypertension are a mean pulmonary artery pressure strictly above 20 millimeter of mercury. This is exactly based on the question you just asked me, Aaron. We saw in the meta-analysis and systematic review that the mean PAP was 14 millimeters of mercury in the very large data set we could analyze, and the standard deviation was 3 millimeters of mercury. So any value of more than the mean and twice the standard deviation were considered as abnormal. So the upper limit of normal is 20 millimeters of mercury. So any value strictly above 20 is abnormal and defines pulmonary hypertension. Then, of course, the story is not over. It's a hemodynamic status, and you have to define bottom left on this slide whether the patient has pre-capillary pulmonary hypertension, defined by mean PAP above 20, but wedge 15 or less, and PVR strictly above 2 Wood units. And then second, from the left, isolated post-capillary pulmonary hypertension due to left heart disease with pulmonary artery wedge pressure strictly above 15 millimeters of mercury, but PVR of 2 Wood units or less. And then the combined pre- and post-capillary pulmonary hypertension, where the wedge pressure is still above 15, but PVR is above 2 Wood units, indicating some kind of pre-capillary remodeling as a consequence of ongoing post-capillary increased pressure. Exercise PH, we'll not discuss it today, but I know, Aaron, that you are very much interested by this topic. So diagnosis of pulmonary hypertension, and more specifically diagnosis of type group 1 pulmonary arterial hypertension, is based on a clinical suspicion and a series of investigations performed by general practitioner first, and then specialist, and then super specialist in expert center. Usually the story starts with patients with an unexplained dyspnea on exercise. And these patients, usually, they are seen by their GPs, by their family doctors. And the family doctors will get the medical history, the physical examination, perform an ECG, measure some biomarkers, maybe measure oxygen saturation, and they will have a sense of a cause. And usually the main causes are heart or lung related, and then the GP will refer the patient to their local referral doctors, specialists in cardiology or specialists in respiratory medicine. And both experts, irrespective of who is first, will have rapid cross-referral to the counterpart. If the respirologist is the first standing in the evaluation, he will certainly perform lung assessment, pulmonary function tests, imaging of the chest, maybe CPET. But if there is any possible pulmonary hypertension, he will quickly ask the cardiologist to perform an echocardiography, for example. And if the cardiologist came first, he or she can ask the pulmonologist to perform additional information. And then based on that, there will be either a very clear cause, which could be COPD, heart failure, etc. And then the patients will be managed according to that. But maybe this will not be clear, and maybe pulmonary hypertension will be plausible. And based on echocardiography and clinical finding, there will be an establishment of a pulmonary hypertension probability. And if the pulmonary hypertension probability is intermediate or high, the patient will have to be referred to a pulmonary hypertension center. Of course, in red, you can have fast-track referral at any time to an expert center if there are warning signs or when PAH or CTEPH are suspected. So on the right, you see what are the main take-home messages. Signs and symptoms of PAH, they may be subtle and non-specific. Second, the most common symptoms are shortness of breath, fatigue, weakness, and chest pain. Clinical suspicion is based on symptoms, risk factors, and medical and family history. When the patients are at a more advanced stage of the disease, there might be signs of cardiovascular abnormalities. And of course, we all try as a community to find new non-invasive screening tools and new biomarkers in order to have early warnings in patients with possible pulmonary hypertension. So the diagnostic investigation for PAH, there are many. Of course, history. Of course, physical examination, where we look for signs of right heart failure. And then, obviously, we have a focus on the heart in these people with shortness of breath and sometimes chest pain and signs of heart failure. Then we look, of course, to the lung. Heart and lung go together. And we can have blood tests such as autoantibodies. Then we look at imaging, chest radiograph, VQ lung scan, CTPA. We look also at exercise capacity in these people, either with a simple test like 6-meter walk distance test or CPET. We have, of course, at the end of this process, the key measure, which is mandatory to establish a diagnosis of pulmonary arterial hypertension, which is by definition a pre-capillary pulmonary hypertension defined by a mean PAP above 20 millimeters of mercury, a wedge pressure of 15 or less, and pulmonary vascular resistance above 2 Wood units. So clearly, PAH is usually not the first diagnosis you have in mind, but at the end of the process, when it is time to perform right heart catheterization, you may have a diagnosis of PAH because it is precapillary pulmonary hypertension, not due to lung disease, not due to a chronic thromboembolic pulmonary disease. And at the end of the day, PAH is more a diagnosis of exclusion of the most common causes. The patients, they may have consequences of this very long process to establish the diagnosis of PAH. And in the guidelines, we try to speed up the diagnosis of PAH. But you see here a cartoon describing a possible classical patient journey with many years of symptoms with initial subtle shortness of breath, which then becomes more pronounced with worsening of symptoms, palpitations, chest pain, emergency hospital visit, and maybe after 3 years or more, a diagnosis of pulmonary hypertension made too late in the course of the disease. So one of our ambition is to have earlier diagnosis. And when you look at the most classic registries published worldwide, from the REVEAL registry in the US on the left, the French second on the left, the Swedish second on the right, and the last on the right, the European-German Compera registry, you see that most patients with PAH, they are diagnosed in functional class 3, meaning that they have already advanced symptoms. And this is a very important message. We need to be more proactive in early diagnosis in these patients. So the goals of care when the diagnosis will be established is to relieve symptoms, to have near-normal daily life, improve hemodynamic parameters, delay or prevent disease progression to right heart failure, avoid hospitalization, improve survival, and certainly we have important treatments right now which target several abnormal pathways, and we should use them as well as we can. We need to be very proactive and aggressive in terms of treatment, and our ambition is to achieve and maintain a low-risk status in order to improve also quality of life and reverse the right heart remodeling in order to have a preserved right heart function. So I will now hand over to Aaron Waxman, to Dr. Waxman, to describe one of his cases. And thank you very much, Aaron, for sharing that with us.
Thank you, Mark. So I'm going to walk through the evaluation of a newly diagnosed PAH patient. And this is a patient who came through our clinic at the Brigham and Women's Hospital. And we'll start off with just a very brief history. When we met her, she was about 36 years old. She had been diagnosed at another center and had moved to Boston, and her history was notable for about 2 years of exertional intolerance that became very rapidly progressive over about 6 months before she had presented to her initial center. She was diagnosed with PAH and was sent up to us on some oral therapy, but was clearly getting worse in spite of that oral therapy. I think importantly, whenever someone is concerned about pulmonary hypertension, sending them right to a PAH center will expedite the evaluation, and it will be a focused and efficient evaluation that includes not only the diagnosis of pulmonary arterial hypertension, but also making sure we don't miss other diagnoses like chronic thromboembolic pulmonary hypertension. A number of warning signs are important to consider as patients progress through this process. One, anybody who has rapidly progressive symptoms where their shortness of breath is transitioning from a functional class 2 to 3 or even a 4, those are people who need to be referred right away. And I can tell you that the centers are more than happy to do the workup. We don't expect non-PH centers to really jump into this. So as those patients are becoming more and more short of breath, their exercise capacity is on the decline, so they might only be able to walk 10, 20, 30 feet. Certainly anyone who has symptoms of pre-syncope, and very concerning if they should have syncope, always raises a red flag for us. And then on physical exam, any signs of right heart failure, such as lower extremity edema or ascites, can be very concerning. So I think the easiest thing is a referral to a PAH center where we're able to do a very comprehensive, efficient, and fast evaluation so that we can get that patient on therapy as soon as possible. So as far as the next steps, it's always important to get a detailed history. We do want to know about any other chronic cardiac or respiratory disease. Very often these patients are misdiagnosed as having some sort of asthma or COPD, depending on their age. So certainly considering that, but I think importantly, if you treat asthma or COPD with the standard approaches and those patients don't improve, then you need to consider another diagnosis. We do want to make sure there's no history of venous thromboembolism, and that includes not just the patient, but also a family history. Certainly, we're always looking for familial disease, so asking a detailed family history. There are definitely associations with certain drugs or toxins, especially in the United States, such as methamphetamine. So we do want to make sure we're checking for any potential exposures that could lead to pulmonary hypertension. Connective tissue disease is very important to consider. Oftentimes those clinical stigmata can be subtle, but nonetheless, checking with a patient about Raynaud's, arthritis, any other considerations with skin changes and telangiectasias are important. Liver disease, especially that with portal hypertension, is specifically associated with pulmonary hypertension, so certainly looking for risk factors for portal hypertension as well as a diagnosis. congenital heart disease, which in the current state of the art is often recognized in utero, if not early childhood, but nonetheless, there are patients who do somehow sneak through not having been diagnosed. HIV is associated, although in the age of heart and more advanced therapies, that becomes less and less, but nonetheless, if there are risk factors, we do want to know. In our area, certainly schistosomiasis is not a concern, but if anyone does travel into, especially in Northern South America, Africa, that is where it becomes more an issue. As far as assessments, kind of the first thing that often comes up is the CT scan, and this is a CT scan that shows you some features of PAH or pulmonary hypertension in general. And what you're seeing on this panel on the left, should cycle again, you're seeing some hazy areas intermittent with darker areas. That is mosaic attenuation, which we can see with pulmonary hypertension and VQ mismatching. It can also be seen with obstructive lung disease, but in this case, we can also see the heart itself. The right side of the heart is enlarged compared to the left, again, suggesting that this may be pulmonary hypertension. And on top of that, the pulmonary artery is quite enlarged. Typically, it should be a little bit smaller than the aorta, and in this case, it's quite a bit larger. The panel on the right is an a CT angiogram, and there are no findings here to show evidence of venous thromboembolism or chronic thromboembolic disease. Technology has advanced quite a bit. Generally, it was always said that VQ studies are the standard approach to ruling out CTEPH. Depending on the technology at your institution, the current state of the art is pretty good with CT. And this is pretty much an unremarkable angiogram. The next and probably the most important screening tool is echo. And this shows you two windows from the echo. On the left is the short axis parasternal view. And what you're seeing here is the right ventricle on top and the left ventricle down below. The right ventricle is large and actually extends off the screen or off the imaging portal there. And the other important finding is if you look at the septum, the interventricular septum, you can see it flattening during systole. And that is that characteristic D shape that we look for that suggests that there are higher pressures on the right side relative to the left. On the panel on the right is a four-chamber view. And here, on the left side is the right ventricle and right atrium, and on the right side is the left. And importantly, what you can see here is that the right heart is bigger than the left. And that also is concerning for pulmonary hypertension. A few more images that we have. This is an example of the outflow tract with the aortic valve right in the center. That color Doppler is actually looking right at the pulmonic valve, and you can see pulmonary regurgitation happening there. This is just there to show you what that looks like, and then you can see the pulmonary artery coming down from that colored jet and dividing into the right and left pulmonary arteries. The other important thing we do with echo is to assess the functional status of the right ventricle. And there are two views that you'll often hear about. This is what we call the S prime. And what it is doing is you can see the dotted window or the window up above. And then there's a dotted line that runs into the annulus of the tricuspid valve. And what this does is measure the velocity of the movement of that annulus with contraction. And that velocity is expressed in centimeters per second. And generally, so long as it is better than 9 centimeters per second, that correlates with a preserved RV function. And in this case, you can see it's 12.7 centimeters. The other important view that we look at is what's called the tricuspid annular plane systolic excursion, which measures using M mode the actual movement of that tricuspid annulus. And again, you can see that dotted line up above that runs right into the tricuspid annulus. and the M mode down below, and we're looking at the excursion between systole and diastole. And here we want to see that difference between about 1.7 or greater centimeters. And in this case, it's 1.6. So it's a borderline reduced. I will tell you before we do this question and answer, we do estimate the pulmonary artery pressure off of an echo by looking at the regurgitant jet through the tricuspid valve. And in this patient's case, the estimated right ventricular systolic pressure came out to around 65 to 70 millimeters of mercury, which is quite elevated. So now we can go to the next audience poll question. And here we would ask, what further tests would you order for this patient, knowing what we've already obtained? A chest X-ray and pulmonary function test. B, a ventilation perfusion scan and then cardiac MRI. C, a right heart catheterization. D, a cardiopulmonary exercise test. E, it's safe to say I don't know, and I'll leave it up to the PAH center.
Thank you, Aaron. While our colleagues are voting, I have a very brief question to ask you. Can you tell me which tests do you find easily performed in primary care, and which should only be conducted in an expert center?
Well, I think, as you pointed out earlier, many of these patients show up as unexplained dyspnea, unexplained exertional intolerance. And I think the basic tests that I think any practitioner should be able to get in that case are some sort of imaging of the chest, pulmonary function testing, and an echocardiogram. I mean, they would be ordering that from other sites most likely. Those to me are the very basic tests that primary care practitioners, even pulmonologists or cardiologists who don't focus on pulmonary vascular disease, can order. I think importantly, the expert centers, though, that's where a right heart catheterization needs to be done, because we do a lot of additional testing beyond just measuring the numbers. And I think the best data comes out of the centers so that we don't have to repeat it. As far as the results, it looks like many of you already are ahead of the game here. Most of you suggested a right heart catheterization would be the next test, and that's absolutely correct. And in fact, we can now go to our patient's right heart cath in just a moment. Generally, at a baseline, we do some sort of assessment of exercise, and in this case, a 6-minute walk distance was obtained, and this patient walked about 380 meters. I think importantly, someone who's 36 years old probably should be able to walk better than 600 meters. So this is a pretty significant reduction in that exercise tolerance. And then an NT-proBNP was obtained. And we often will get this so that we can plug this into one of our various risk calculators, which you'll hear about later. Now, the right heart catheterization. Again, I really encourage people to send patients for right heart cath to a PAH center, because we do additional testing beyond just measuring these numbers. But this is where the diagnosis is made. And you can see here the right atrial pressure. The third column there is 4 millimeters of mercury, which is the mean pressure. The right ventricular pressure, we have a systolic of 62 and a diastolic of 2 millimeters of mercury, and then an end diastolic pressure of 8 millimeters of mercury. We do look at that end diastolic pressure as a good index of where the right ventricle is, as far as whether it's in a state of dysfunction or not. PW is the pulmonary capillary wedge pressure, and here too we look at the mean pressure of 11 millimeters of mercury, which is within normal limits. And then the pulmonary artery pressure, here you can see the systolic pressure of 61 over a diastolic of 16, and a mean pulmonary artery pressure of 37 millimeters of mercury, which here has made the diagnosis, as Mark had pointed out much earlier, that greater than 20 is considered abnormal. So we clearly have a high pressure. And then we take that pressure relative to the pulmonary capillary wedge pressure of 11, and the gradient between those numbers shouldn't be greater than 12. And you can see here that gradient is about 26, which would suggest a pretty high resistance, and we'll get the resistance on the next page of these data. You can see also on the far right, there are timestamps, but just to the left of those timestamps are the saturations within each of those chambers, and those saturations are on the low side, which would also suggest a potential impact on cardiac output. These are the additional numbers. You can see there the PVR, the pulmonary vascular resistance, which here is being measured in dynes. And I think you saw in the definition referral to Wood's units. To get from dynes to Wood units, you divide by 80. So this is about 4.7 Wood units. So quite elevated when we consider 2 or less to be within normal range. You can also see, oh, I just hit the cardiac output there is 5.4 liters per minute and an index of 2.9. So the other important thing we'll do during a catheterization is vasoreactivity testing. And the importance of vasoreactivity testing is that it provides sometimes an opportunity to treat with simpler medications, such as calcium channel blockers if a patient has reactivity. And you can see the definition of a positive reactive response there in the orange panel of greater than 10 millimeter of mercury reduction in pulmonary artery pressure, and they need to also get below 40 millimeters of mercury in pressure overall. And there should be an increased or at least no change in cardiac output to call it a positive response. And those patients may be candidates for calcium channel blockers. I think the other important thing that vasoreactivity testing gives us a sense of is the severity of disease. Many patients are not reactive to that extent that we would consider calcium channel blockers. But they may have some degree of vasoreactivity, which helps you identify patients who have had this disease much longer than we would think. If patients do end up on calcium channel blockers, they need to be followed very closely. The things we use to do vasoreactivity testing, most places now use nitric oxide because it's very easy, it's very short acting, and has really no side effects. Other places may use inhaled iloprost, especially in Europe, and in the US, there are some places that will use inhaled epoprostenol, as well as IV epoprostenol, but that gets a lot more complicated. And we have another audience poll question. Which risk category would you assign this patient? A, low risk, B, intermediate risk, C, a high risk, and D, I don't know. And I'll throw a question out to Mark while we're waiting for the response. Mark, for risk stratification, when should clinicians use the 3-strata model, which includes low, intermediate, and high risk, versus the 4-strata model, low, intermediate, high, and high risk?
Yeah, thank you, Aaron. It's a very important point from the last version of the guidelines. We realized that at baseline, 3 strata was enough, because what we want to know is what is the degree of severity and what is the risk of death at 1 year. And according to what we evaluate, the decision will be between finally 2 main decisions, initial aggressive triple combination therapy or initial double oral combination therapy. So we want to know if the patient is high risk or the patient's intermediate or low risk merged together. At follow-up, it's much more subtle because the vast majority of people are in fact in intermediate risk, but they don't all look the same. And finally, it was quite important to substratify the intermediate group in an intermediate low and intermediate high, because the intermediate high, they look pretty much the same than the severe end of the spectrum, and they might need more aggressive management. So that's the reason, and I let you comment on the results.
So I think what's impressive for all of you is that it looks like many of you put this patient into an intermediate risk, which I think also gets to that point that Mark made, that very often because of the strata, most patients end up in intermediate risk. And on that note, we can look at what the three-strata risk model includes. This is the original three-strata risk model. And again, the vast majority of patients end up in that intermediate risk category based on these criteria. And these have been updated for the three-strata risk models, which added some assessments of the right ventricle, including echo, cardiac MR, and hemodynamics, which improved this three-strata risk model. But I think, as you'll hear from Mark later, breaking that intermediate risk group down into a low and high subgroup improves the calculator even better. We have a couple of questions that came up before we go to the next poll question. Is right heart catheterization required to make a definitive diagnosis of PAH? I'm not sure what WG stands for, but I assume group 1, WHO group 1. And I would say that for all forms of pulmonary hypertension, to define what kind of pulmonary hypertension they have, the right heart cath is absolutely required. And Mark, there's another question here. Can you discuss why European guidelines use pulmonary vascular resistance greater than 2 as part of the definition, whereas actually others use PVR greater than 3? I think the important thing is others don't use greater than 3, but it's European, so I'll leave it to you.
Yeah, thank you, Aaron. It is exactly the same answer than the one you asked me on mean pulmonary artery pressure at 20 or more. In fact, in the systematic review and meta-analysis we performed, and there is a lot of literature right now on that topic, the real upper limit of normal of PVR is 2 Wood units. And it is not one part of the world using 3 and one part of the world using 2, but the true upper limit of normal is 2. And then, of course, you may decide to keep a safety buffer and consider that between 2 and 3, it's a gray zone. However, PVR above 2 means abnormal value and increased resistance. So thank you, Aaron.
Yeah, I would stress that while this is all based on European guidelines, the US has openly and very excitedly accepted those guidelines as our own. So we go by exactly the same cutoff. So that brings us now to another audience poll question. What treatment strategy would you recommend next for this patient? A, initial oral monotherapy. B, initial dual combination therapy. C, oral therapy plus intravenous therapy. D, initial intravenous therapy. E, I don't know. While we're waiting, there is a question about, can we discuss some places, why some places use adenosine for vasoreactivity testing? There aren't many places left that do that because it makes patients feel pretty miserable. And it's so much easier as far as side effect profiles to use things like either nitric oxide or epoprostenol. In the US, iloprost is not generally used because we don't have it in the same formulation that they do in Europe. So the findings on the poll, most of you chose initial dual combination therapy. So I would agree with that, and I will hand this now back to Mark to talk about therapy.
Thank you, Aaron. Very, very interesting case indeed. And the treatment options in these patients were, in fact, quite clear. I mean, the audience is very well aware of the condition, and they rightly regarded that this patient was intermediate risk. And based on that, this patient was a good candidate for initial oral dual combination therapy with an endothelin receptor antagonist, in that case, ambrisentan, and phosphodiesterase type 5 inhibitor, in that case, tadalafil. So, in fact, we have quite a lot of drugs approved for PAH. PAH is a rare condition, group 1 pulmonary hypertension. It's between 15 and 50 people per million inhabitants in the Western countries. And despite the rarity of this condition, there were many drugs developed thanks to the willingness of patients to contribute to the studies, to doctors to make randomized control trials, and to pharma and scientists to develop new agents. And the three pathways are quite clear, in fact, in the literature. You have the endothelial pathway, which is a vasoconstrictive pathway, and proliferative pathway, and you can interfere with this pathway with endothelin receptor antagonist. Then you have the nitric oxide pathway, and this pathway is vasodilatory, and you can interfere with this pathway with either PDE5 inhibitors or soluble guanylate cyclase stimulator. And finally, the first developed family of agents in PAH is a prostacyclin pathway with either prostacyclin analogs ranging from intravenous epoprostenol to inhaled iloprost and to oral inhaled IV or sub-Q treprostinil. So at the end of the day, you have quite a lot of benefits observed in clinical trials with these agents. And what is really interesting in the last 15 years is that after evaluating one drug versus the other or one drug after the other, it appeared quite clear that the way to go was to combine drugs either initially or sequentially, and that background therapy can be monotherapy and then you add on treatments sequentially, or you may consider upfront combination therapy as indicated in the guidelines as we discussed a few seconds ago. So here on this cartoon, you will see it will be crowded very soon. On the left, you have PDE5 inhibitors. On the right, soluble guanylate stimulators. These two should not be combined together, so they are far away. But the yellow one, the prostacyclin in green on the top, and the endothelin receptor antagonist in blue at the bottom, they can be combined with any of the others. And you see here all the randomized control trials which have tested combinations of drugs together. It's quite impressive for rare disease. There is a huge number of randomized control trials convincingly demonstrating that either initial combination therapy or sequential combination therapy is the way to go in symptomatic PAH in low, intermediate, or high risk baseline status according to the three strata. So in the guidelines, this is very well reflected, and I'm going to move on and show you that in patients like this lady on the left in the green circle, you see that when you are low to intermediate risk, initial oral combination therapy with an endothelin receptor antagonist and a PDE5 inhibitor is recommended. If this lady was in high risk, initial triple would be considered with parenteral prostacyclin on top of the two oral drugs. And you can see on the right the detail of the European guidelines with the class of recommendation and the level of evidence. So quite a reasonable amount of data demonstrating that initial combination therapy with an ERA and a PDE5 inhibitor is of interest in a patient with intermediate risk PAH. Now, at follow-up, after initiating therapy, as Dr. Waxman said very clearly, the patient should be monitored very closely. And you see here the recommendation for follow-up assessment at baseline at 3 to 6 months after each change of therapy, and in stable patients or in case of worsening. And you see that we repeat quite a lot of non-invasive measures. And based on this recommendation to repeat quite regularly non-invasive measures, there is this European 4-strata risk model where we took the three most important non-invasive measures: 6-minute walk distance, biomarker BNP or NT-proBNP, and the functional class. And depending on the level of disability evaluated by these non-invasive markers, you can consider that the patient is low risk, and we consider that it is a goal of therapy, or intermediate low, intermediate high, or high risk. This will be quite important because when we follow these patients up, we will have to make a decision based on these evaluations. And now I'm going to show you that in these very patients followed by Dr. Waxman in Boston, the patient, when she returned to the clinic, she saw the doctor and the clinical nurse specialist, and the clinical nurse specialist noted that the patient had not improved or not improved sufficiently. And in fact, the repeat test by the pulmonologist and radiologist indicated that she had progressed to functional class 3. So I hand over now to Aaron to discuss patient participation to clinical trials. And
before I go ahead, there are a number of questions. I think some of them will be addressed as we move through, especially talking about sotatercept. And some of these others we can pick up because I think Mark may have some thoughts as well as we get closer to the end, because some of these questions are really important. So I'm going to talk now about where we are in development of new therapies. And I think for all of you out there who either care for patients or want to make sure those patients are informed of the opportunity for a clinical trial, there are a number of places that those patients can look, as well as their providers. There is the Pulmonary Hypertension Association Clinical Trial Finder, which you can get through the PHA's website. Same with the PHA Classroom, which is very good and loaded with information. I think for those patients who really want to think about clinical trials, obviously the clinicaltrials.gov is a huge database of all the clinical trials that are out there throughout the world. And I think that's probably your best place as a provider to find the best trial for your patient. As far as investigational therapies, there are a lot of things happening. Many of these are happening more in the lab right now than they are in people. A couple of things on this list, like the BMP ligands, FK506, there's some interesting data out of Stanford that shows some potential with this approach. Some of these others targeting the Rho kinase have been investigated for a long time. The activation of the apellinergic pathway is an approach targeting metabolism, which is, I think, a realm in this pulmonary vascular world that we have yet to really target. These are areas that some are in active investigation right now. You can see the inhibition of the tyrosine kinase and PDGF pathway. There are two agents in clinical trials now. Imatinib is an inhaled agent, as well as seralutinib, which is the GB002, is now just about to go into phase 3 trial, and both of those have some promising early results. These others are all really within the realm of the laboratory right now. There have been some early studies with trimetazidine and ranolazine, which target mitochondrial abnormalities, which are really a feature of advanced disease and are part of RV dysfunction progressing to RV failure. There's always been interest in metformin and what role glucose or insulin resistance plays in pulmonary vascular remodeling. These other things are all really currently in really early phases. I do want to point out about reversal of iron deficiency, which is a very easy thing to do and has really become part of the care of patients with pulmonary hypertension, in that many of them, just like congenital heart disease patients, often can become iron deficient, even though they may not be completely anemic. Importantly, iron plays an important role in extra mitochondrial energy production as well as regulation of vasomotor tone. So sometimes you can really make people feel a lot better by correcting their iron deficiency. The anti-inflammatory and immunosuppressives have had some case reports and some interesting data, especially in patients with various connective tissue disease presentation. And then the whole idea of inflammation being a big part of pulmonary vascular remodeling. So moving on to treatment options, this patient was on what she should be on based on her risk category and was clearly getting worse. I can tell you that this patient did not tolerate prostacyclines, which is why she did not go on the standard triple therapy. So we offered her the opportunity to go into a sotatercept study that was being done at our institution. So an audience poll question, what is the mechanism of action for sotatercept? A, via the endothelin pathway, B, via the nitric oxide pathway, C, via the prostacyclin pathway, and D, via the rebalance of BMPR2 signaling, and E, I don't know.
Maybe I will ask you one of the questions in the panel, Aaron. In your very patient you described, would you have considered initial triple combination therapy with parenteral prostacyclin because she was quite severe in terms of symptoms? And maybe in the same line, do you consider intravenous or subcutaneous prostacyclins as a very end stage therapy, or you consider it a little bit earlier in patients?
No, great question. In this patient, we did consider IV therapy, and we actually did try, but she could not tolerate any prostacyclin. It caused really intolerable side effects of muscle myalgias and nausea and vomiting. So we were kind of stuck with her. To the other part of your question, as far as when to use a prostacyclin, I really am aggressive with the use of prostacyclins. I don't want to wait for that patient to go into heart failure to start it. I want to really aggressively start it at an early functional class 3 and really titrate it aggressively with a goal that maybe I can over time see significant improvement, and even then consider switching somebody from a parenteral to an oral or inhaled formulation to make their lives easier. But to me, the triple therapy, which really the European data and your own data shows is the best approach as far as getting our patients feeling better and living longer.
Yeah, thank you.
The results are in, and people are clearly reading what's out there in the literature, because it's via the rebalance of BMPR2 signaling is the correct answer. And with that, we can talk briefly about sotatercept and what it is. I think importantly, it's long been known now for pretty much 20 years that pulmonary vascular remodeling, especially in PAH and familial PAH, is a result of a dysfunction of the BMPR2 receptor. And when that dysfunction is set in, what happens is there's an imbalance because of increased production of activins and growth differentiating factors, and those drive a pro-proliferative environment, and there's a loss of the balance of anti-proliferative mediators. What sotatercept is a novel first-in-class fusion protein. So it's linked to an FC portion of an IgG molecule, and it's an engineered trap, if you will, that grabs all of these excess activins and growth differentiating factors, and by grabbing them and taking them out of the circulation, it serves as a way of rebalancing the pro-proliferative or activin R2 receptor-mediated pathway versus the anti-proliferative pathway of the BMPR2 signaling. And by shifting that balance back to what it should be, kind of a nice equal pro-proliferative versus anti-proliferative state, we can certainly stop the progression of disease. And I think more and more we are seeing reverse remodeling of the pathologic change, which has been seen in our phase 2 and 3 trials. This is the result of the Pulsar trial, which was the phase 2 trial. I do want to point out that the primary outcome was pulmonary vascular resistance in this study, and we did see a significant improvement or decrease in pulmonary vascular resistance in those patients who were treated with sotatercept. And what you're seeing here are the secondary outcomes, including the 6-minute walk distance, where we saw a significant improvement in 6-minute walk distance compared to their baseline walk at week 24, and then a further improvement at week 48. We also significant reductions in NT-proBNP, and then we also saw significant improvements in WHO functional class. And I think what you can see on this graphic is that the upper panel are those patients who started out on drug and continued on drug into the extension phase. And then we also have down below those patients who started out on placebo and then transitioned over to drug after the blinded phase. And I think one of the striking things that I saw in this trial was that those patients who had been on placebo actually caught up to those patients who were on drug throughout. Now, this is the data from the Stellar trial, which was the phase 3 trial, which was recently published in the New England Journal. And this is the primary outcome for that trial, which was the 6-minute walk distance. And here you can see a significant improvement in 6-minute walk distance at 12 months, and then at 12 weeks, and then at 24 weeks, which was really an excellent finding in this study. And the last slide I'm going to show from the Stellar trial are the treatment emergent adverse events. And you can see here, there were some events that showed up more frequently in the sotatercept group, including some bleeding and some telangiectasias. Many patients saw an increase in hemoglobin of about 1 to 2 grams. And then so very few patients we saw thrombocytopenia. Those patients who had epistaxis, it could have been related to telangiectasias, but we're still sorting a lot of that out. But overall, this was a remarkably well-tolerated trial. And I'll hand it back to Mark.
Yeah, thank you, Aaron. You briefly presented that there are many drugs in development in PAH. It's a very active field in medicine. So I will be very brief on some drugs in developments. So tyrosine kinase inhibitors, you mentioned imatinib. There are some imatinib studies right now, either given orally or by inhalation. And this is very interesting to study. And we look forward to having results on these either refined oral therapies, trying to find the best tolerated dose, or the inhalation in order to prevent or limit the side effects observed with oral administration. There is also another drug from the tyrosine kinase inhibitor family, seralutinib, which has been tested in a phase 2 trial, namely TORREY study. And in this phase 2, there was an improvement in pulmonary vascular resistance and a numerical improvement in 6-minute walk distance. And we look forward to having possibly a phase 3 study launched soon. Regarding the serotonin pathway, there is a tryptophan hydroxylase type 1 inhibitor, namely rodatristat, which is currently analyzed in a phase 2b study. And we should have data on this oral drug later this year. So this is another promising pathway. And then we have also established pathways like the prostacyclin pathway with new oral prostacyclin receptor agonists like ralinepag. And there are some studies on ralinepag, which are outcome studies. And these are very ambitious, large outcome studies, which should be still recruiting patients in the next few years in order to provide strong data. So I hand over to Aaron before closing.
Okay. So our patient, as Mark had pointed out earlier, we generally follow patients every 3 to 6 months especially as they improve. This patient was in a clinical trial, so we actually followed her monthly. This drug is administered every 21 days as a subcutaneous injection, and while now the trial is actually shifted to home delivery of the drug, during the clinical trial, these patients would come in every month for their drug. On her follow-up evaluation, she had actually dramatically improved by 4 months and was essentially a functional class 1 and has maintained that status since then. So I think the other important thing we just wanted to touch on briefly was the care coordination for these patients. These are complicated patients, and that is one of the important reasons we encourage referral to PAH centers. We have a multidisciplinary approach. I think it's important that we are working with the primary care providers, as well as these patients have a lot of comorbidities many times, especially rheumatologic, clearly cardiologic, and pulmonary comorbidities. And I think it's really a team approach that includes social workers, pharmacists, in some cases interventional radiology and interventional cardiology. Certainly those patients who might have chronic thromboembolic disease. We also want to think about the cardiothoracic surgeons who can do the pulmonary thromboendarterectomies. And then, of course, transplant is also an important consideration for these patients. Selecting the right therapeutic strategy really requires an understanding of what are the risks versus the benefits. What is the patient able to not only tolerate, but work with? Many of these therapies require the patient to be able to be adept at it. You talk about IV therapy. The patient needs to be able to manage their IV therapy from catheters and subcutaneous injectors to pumps. And that can be complicated, and not all patients are able to do that. We also have to think about comorbidities, comorbidities that may impact a patient's ability to use a drug, but also comorbidities that put patient at risk for side effects as well as other adverse events. And then the side effects themselves. All of these drugs carry some kind of side effect, but I think once you gain a lot of experience with these drugs, it's actually not hard to work around those side effects and make sure our patients can get on these life-saving therapies. So to conclude, I think it's clear PAH is a devastating and progressive disease in which outcomes, in spite of all the progress we've made, remain suboptimal. The currently approved therapies target one of 3 biologic pathways, as we've gone over: the endothelin pathway, the nitric oxide pathway, and the prostacyclin pathway. New strategies and therapeutic targets are still needed, and I think we're on the verge of a whole new world of taking care of these patients as we start to move some of these experimental research studies to the clinics. And emerging options such as upfront triple combination and new therapies such as sotatercept may help, and I think are very likely to help address the unmet clinical need. And I will stop there, and I think now we can start to address some of these questions. I'll start with how does one reconcile the drop in mean pulmonary artery pressure and pulmonary vascular resistance without a corresponding increase in cardiac output and index among patients receiving sotatercept? Should the decrease in pulmonary artery pressure and PVR lead to an increase in cardiac output and cardiac index? I'm happy to jump on that one. I think importantly, when you look at the data from Pulsar and Stellar, cardiac output was normal at rest. And I think to ask for cardiac output to go up further there's just no reason for cardiac output to go out. There is a study coming out soon where we looked at exercise and the response of cardiac output. I think what ultimately the issue is oxygen delivery, and the hemoglobin does go up in these patients. And pretty much every patient on sotatercept does have an increase in hemoglobin. And when you think about the components of oxygen delivery, that increase in hemoglobin and then the reduction in pressure, and more importantly, the marked reduction in pulmonary vascular resistance, improve blood flow, and probably improve blood flow not only through the lung, but also at the level of skeletal muscle with improved oxygen delivery where those exercising muscles are. And it looks like while there may be some marginal improvements in cardiac output, the bigger improvement is in oxygen delivery. And when you think about the laws of thermodynamics, if you have a marked improvement in oxygen delivery, you don't need to have an improvement in cardiac output.
Thank you, Aaron. I will take one question about starting PDE5 inhibitors without right ATCAS. So we discourage that for sure. Some people think that because PDE5 inhibitors are so-called simple drugs, we may consider treating patients without a firm confirmation of the diagnosis. In the guidelines and in clinical practice, we are very clear that when you use PDE5 inhibitors for pulmonary hypertension, you need to have a firm confirmation of pre-capillary pulmonary hypertension. And even if you consider using off-label that drug, you need to have a definite diagnosis of pulmonary hypertension, and you don't treat a patient only based on echocardiography. And I can take maybe a final question on sotatercept in pediatrics. We are all very happy that there is an ongoing randomized controlled trial on sotatercept on the clinicaltrials.gov. Of course, this is a small study, and as one of our colleagues mentioned, there are some contraindication for being recruited in that study, some exclusion criteria. And we know for sure that at this stage, using sotatercept in pediatrics can be done exclusively in a randomized control trial. And we hope that in the future, there will be a full program after this initial randomized control trial currently ongoing. Thank you very much for inviting us for this discussion. I wish you a good rest of the day.
Thanks, Mark, and have a good night.